Welcome, everyone. Thanks for your patience as we get started here. The first minute or so of borderline awkwardness as we allow people to just sign in. But I do, hello, everyone. Welcome to our Casual Conversation series. This is where we get to kick back and not just hear, ask questions to well-known experts, but actually get to learn about them. So I've really enjoyed doing this series. I have known Dr. Fitzgerald a long time, and still I'm always intrigued by what she has her hands in. So I'm really excited, Dr. Fitzgerald, to have you here with us today. So welcome. Welcome participants, and welcome to you.
But thanks for having me, and love doing this. So thank you very much.
Yeah, and I'll give a brief introduction, but then we'll open it up to some personal questions. So for those of you who might not know Dr. Fitzgerald, she is a neuro optometrist. She's actually been practicing for more than 35 years and went on after optometry school to be board certified by the Neuro-Optometric Rehabilitation Association, or NORA, and is actually the acting president of NORA. So I've got some questions for her around that. And she's authored publications. I was just telling her before we, when we first jumped on, before we opened this up, that I learned of all the books that she's written. And I just ordered one of her books that I'm gonna let you know about, and teaches continuing education courses. We've been so fortunate to have her as faculty in our 360 Neuro Health. So it's an honor to have you here, and you're always a fan favorite.
Well, thank you. I appreciate it.
All right, so we'll go ahead and get started. So I just mentioned you've been an optometrist for more than 35 years. What inspired you to become an optometrist?
Absolutely. I was actually an undergraduate, and I was looking, my folks were in medical. My mom's a nurse and my dad was a pharmacist. So I had some background in it. But when I went to undergrad school here in Iowa, I met a very dynamic optometrist, female optometrist. She was 4 females of her whole class. She graduated on VJ Day, and she had an incredible amount of energy. I got to meet her at Careers Day at the college, and I needed a job for the summer, and she offered me a job for the summer. And so I was able to take her up on that. She was in Wisconsin, in Green Bay, Wisconsin area. And I got up there, and she loved to read Harlequin romances, but drive at the same time. I told her I was a pretty good little driver. And so I read about 4 grocery bags of Harlequin romances. So she loved her summer, and I learned a lot. But one of the most incredible things, and this would have been back obviously in the 70s, and she had a young girl come in, 14 years of age. They had found her to have failure to thrive. She wasn't doing well in school. And she just did the eye exam and said, there's more here. In that particular time, we couldn't do blood workups very well. So she did hair analysis, and she discovered this young lady had no thyroid. And so by doing vision rehab and vision therapy, and then treating that thyroid, getting her to the right place, this young lady graduated high school. She was considered never to do that. That was so exciting for me to see her do that, and how influential a vision exam can be. And so at the end of the thing, though, my summer, she just said, DeAnn, what are you going to do? And I said, well, I could go into pharmacy school. I got accepted into law school in an undergraduate optometry. And she said, ask your dad, because I said, my dad, a pharmacist, really wants me to do that. She goes, ask your dad if he thinks of his job as a hobby. And I said, oh my gosh, I don't have to ask my dad that at all. And so she said, I think of my job as a hobby. And so in that summer and working with her, I truly believed, once again, and her energy for that, it was very convincing. I had an 8-hour drive home. I told my parents I was going to go to undergraduate optometry school, and they, with a little bit of trepidation, the rest is history. So she was a great influence.
Oh, that's a fantastic story. And so you were exposed to the neuro rehab
early on.
So did you already know at that point, I'm going beyond traditional optometry into neuro optometry?
Had no idea. What happened then is I picked Pacific University, which was a little bit more non-traditional in optometry, but at the same point in time, it was just a great exposure. Actually, my thesis was done on before the Readalizer and the Visiograph was ever invented. I was using press-on stickers to look at 8th graders' eye movements, and that was my thesis. And so my professor was so disappointed when I didn't stay for research in that. And it was interesting then, of course, 5 or 6 years later, they came up with that. But I didn't know I was on that path. And so I really honed in on the structure of optometry, you know, eye disease, trying to determine that. And so it just came natural for me to want to make that change. So I got disappointed a little bit in optometry, traditional optometry, because I had so many people coming in I couldn't help. You know, and these folks would come in and they get 0 to 100. They'd be little children that couldn't read or weren't functioning or walking correctly or couldn't participate in a sport. Or they'd be Mabel and Glenn, 65 years of age with macular degeneration or a stroke. And I just knew there had to be more. And so to my great surprise, I was able to partner with a very progressive OT. And she and I worked well together. And so in 2007, we opened up Vision in Motion. And that partnership and that modeling really created and really catapulted us forward. And because of her background, and because I was really wanting to do more than just eyes, it really helped me move forward with that. So I can't say enough about partnerships. I love working with PTs, OTs, athletic trainers, speech pathology, you know, speech therapists. Everyone has something to bring to it. But if we can't get the eyes situated in a certain fashion, then once again, we're not going to be able to treat that patient completely. So I get excited about it, and I love working with patients.
That's awesome. And, you know, I have just grown to have such a love for the eyes. You know, the eyes are the window, can be the windows to the brain. And as a physical therapist, doing some oculomotor testing, but always seeing these patterns and being able to meet neuro-optometrists and learn so much and the importance of posture and the eyes. You know, I'm curious, what's your perception of the evolution? So you know, you said in the 70s you met an inspiring neuro-optometrist, and now serving, you know, as president of NORA. What has that evolution looked like, and perhaps even where do you see things going?
Yeah. Once again, I think we are moving it forward, and I think the decade of the brain actually allowed us to even move it further. So it used to be said that 70% of our brain's dedicated to vision in some fashion, 80% of all sensory goes through our eyes, and 90% of people who have some sort of trauma will have a visual affect. And we know now today in this moment, it's really 100% of our brain's dedicated to vision in some fashion, 80% of sensory, and 100% of people have some sort of visual affect. And we know now that if we don't get right away on treating that, those folks will remain in a recovery state, not recovering well for 3 months to a year or longer. And so that really drives me forward. So I think the evolution has been moving from body and eye to actually brain, and then being able to use, for me, I use the eyes a lot to facilitate that. And other professions are using that too. And then adding with that posture, vestibular, and then auditory. We just have found that that's been so important to combine that all together.
It really just is so multisensory, that multisensory reweighting and not tapping, either under tapping or having this hyperactive system where we're, you know, very sensitive to auditory or visual or vestibular information. And I think really tapping into that and grounding just becomes so critical in our treatment. And I've really enjoyed the talks through the years on how much you utilize that grounding and support services. And we love to talk about the cerebellum. We just need to have an entire day where we can talk about the cerebellum. So, well, thank you for sharing that. And I did want to let our listeners know one of, you know, the books that I just ordered from Dr. Fitzgerald. The title of it is Vision Rehab Primer for Non-ODs, which is great. And I'm curious, you know, what inspired you to write to non-ODs, and then if you could had a second edition, or, you know, what would you add, or would you change anything from your first book?
I think it was really important with that particular one to get all of us on the same page of verbiage. I think that once again, between OT, PT, optometry, athletic trainers, that we have a different verbiage when we mean the same thing. And so part of that book was to get the verbiage between the professions to be more common. That was number one. But number two, just to really emphasize the need for that partnership with OT and PT. Once again, I can't just do something with the eyes and have an expectation that it's going to change that. I have to move that patient. For me, if the patient doesn't allow me to move them, I'm not going to change them. And it won't matter how much prisms, lenses, tints, or whatever I do to manipulate that. If I can't get them to move, I'm not going to change their brain. So I'm using their eyes as that solid form to do that. And so that partnership with OT and PT. So when I went to school, I might have learned neck up, but OT and PT all learned neck down, athletic trainers all learned neck down. When you combine that, it combines our therapy so rapidly, we're able to help those patients so much quicker and faster. And so then the patients really feel how they're getting better. And so as a result, I just think that combination is so important.
And that's great. And I'm, we had received so many questions prior to today's webinar up until right before I turned this on to record it. And we'll get through as many questions as we can. And if, I'll be at the end if I have time, just from what you said there. I think it seems like we may compensate. Well, we know we compensate in posture and a lot of guarding, but I think there's a lot to learn from, are we compensating it through our eyes? And as clinicians, what can we look for? So if we have time, I would love to come around and revisit that. So you've mentioned some aha moments, inspired in the 70s to go into optometry, and inspired by what you've seen and working with therapists. Are there any other kind of aha moments that you have, or advice that you have for clinicians regarding just the importance of assessing the eyes and having this kind of neuro optometry viewpoint?
Absolutely. First of all, if there's a way that we can make some things easy, whether we use a survey to be able to determine, is vision helping the recovery of this patient, or is it hindering it? And we've got to figure out that first. And then can we start with vision, or do we have to start somewhere else because they're too symptomatic? So I think that's really important. So it's symptom mitigation. So we have to start with where that patient can start. And then we have to see how we can manipulate certain types of things. So I'm fortunate to be able to have prisms and lenses because I can change space. So a lot of times with these patients is that they're going to have that ambient system, that peripheral system, be mismatched with that focal ventral system. And one of the ways I can help ease that patient back into getting into that spatial aspect so that we can blend that better together is through prisms and lenses. I can change the space without moving them. I can change their space in a perceptual fashion and then have them do vestibular activities or cognitive activities while they're doing that. And that can make that brain unlock a little bit more quickly so we can do some of the other things that we do. And I feel like that's the importance of that. And so a lot of times I might see patients, I'm very fortunate, I get to see patients early on, sometimes 3 to 5 days out of their injury, depending upon where they're being seen. But if I'm seeing that patient 3 and 4 and 5 months out, I'm going to probably treat them a little bit differently than if they're 1 or 2 days out. And one of the things is I've got to start where they're at. I got to figure out what symptoms are keeping them from recovering the way that they need to, and how can I mitigate that with vision. So to give a little bit of an example, I have a 7-year-old little girl who's a twin. She's actually had a feeding tube since she was 6. We've seen her, encouraged her to maybe want to do some combined multi-therapies. She will only eat anything that's liquid. And so what we did is we combined vision, vestibular, and proprioceptive activities with her. And I do it in an immersion way. So I wanted to see her every day because she's a pretty intense little girl. It was passive. By day 7, her mom reported that, and she would never do this, she immediately started eating off her mother's plate a potato chip. How does vision therapy or vision rehab affect someone to become a better swallower and a better eater and to finally want to thrive? And it's because it's all connected. And so if she doesn't find something appealing in her eyes, it's not going to be appealing to her stomach. It's not going to be appealing to her taste buds. That would have to be one of the biggest things today that we're dealing with this little girl, and she's doing awesome. But it's because we combined those types of things. So she had lots of PT, lots of OT, and everyone did brilliantly. That was just the mismatch for her, and we were able to make that connection. And so now she has independently started to eat off her mother's plate or grab something she ordinarily wouldn't. And that was through vision therapy and vision rehab.
You know, thank you for sharing that. That is so inspiring and just screams the importance of multisensory, the neck, the vision, auditory, vestibular, and the gut-brain connection, and just a beautiful story. So thank you for sharing that. And I think I'll use this opportunity, because we received so many questions, to move into some of the ones we've received from our listeners. And one of those, actually we received a couple, are about Prisms. So here's a question, and I'm going to combine a few into 2 or 3 together. Is a patient that has binocular dysfunction and is in need of serial Prism glasses, should we hold off on vestibular rehab until she gets her final pair of glasses? Well, I'll stop there, and then I have a couple more about Prisms.
I think once again, if you're the OT, PT, athletic trainer assessing that individual, and you're trying to make a decision on, and you don't have an eye exam referral yet, I think once again, you have to start with where they can. You want to reduce their symptoms. And one of the things then is to get them in and have that eye exam. Now, from my standpoint, what happens is the moment I put a Prism on an individual, they change. And so as it shifts that space. So sometimes even in my testing, it's diagnostic for a change. What ends up happening then when I prescribe it, oftentimes base in and base out, base up and down Prisms, those would do fix more the shoulders, the hips, and the eyes, so that binocularity. Yoked Prisms affect more space. I'm going to open up a part of the space. Perhaps they're having sort of a neglectful affect towards the right, or they're listing towards the right, or they're not paying attention. Then I can open up space by either using a plus or minus lens or yoked Prisms to change their perspective on where they are in space. And oftentimes what we're changing is part of that cerebellum, rhythm and timing. That's why I love the cerebellum. And for us in optometry, the yoked Prisms help us move that when the patient can't.
Okay, and then a question here from that is, when someone is in Prisms, do they have to forever stay in Prisms? Do they wear them 100% of the time? Is it unique to each patient?
Unique to each patient and probably practitioner. I use a ton of Prism in therapy. I probably prescribe less than 1%. And part of that reason is that Prism is very hard to get ground into the glasses. So I do use a lot of press-on Prism for third nerve, fourth nerve, and sixth nerve palsies, or if I'm doing something with that space. But if I'm going to be doing something that needs to be space and they need to have that Prism, I'm going to get it ground in. Unfortunately, it just takes about 2 weeks. So for me, I use more Prism in therapy using eye-hand coordination, balance, vestibular, compression to try and get that brain to change.
And just for our listeners, for clarity, you know, you've written a paper, actually part of a team that published a paper on kind of scope of practice. And, you know, Prisms are just out of the scope of practice for therapists, is my understanding. I just would like for you to clarify that.
Yeah, I would like to reiterate that it's really important, an optometrist or a neuro-optometrist, but someone to get on board to tell you the structure of that eye and even the function of that eye. But right now, today in the 50 states, Prisms and lenses are under the professionalism of the ophthalmologist and the optometrist. There is really no one else that has that. Tints are under a few more professions. But that's why, once again, I think it's so important that we're communicating. I want you to be able to take my patient, and I can write maybe how I want you to work the therapy out, but to be able to work together to have that patient do well. So I'll prescribe the the glasses, the prisms, and then be able to write an order for you to be able to do the therapy. And I love that because my patients come from a very far area, so I have to be flexible in that. I have patients that come from a 9-state area. So oftentimes I might see that patient, I would do my my assessment of them and then make my recommendations.
Oh, okay, thanks for that. I hadn't thought about working actually with someone in therapy under the guidance of a neuro-optometrist. It seems they choose. They come see us for this part, and they go to the neuro-optometrist for that part. Now here in Austin, we're fortunate to have quite a few neuro-optometrists. This is a common question, I'm sure you hear it all the time, is what do you do if you don't have access to a neuro-optometrist? Do you refer to an optometrist or an ophthalmologist or a neuro-ophthalmologist?
So I think the number one thing we always have to figure out is, does this person have a structural problem? Do they have a 3rd, 4th, 6th nerve palsy? Do they have a tear in the retina? Do they have a traumatic iritis? Do they have something else that's going on that we need to not be doing therapy on something that's broken? And I think so then an optometrist for me, and you want to cultivate that optometrist, call that optometrist up and say, hey, I'm an OT in the area. I see a lot of patients with this. I really need your guidance on this. Would you be willing to talk to me about this patient? Call me up and say, hey, Johnny's 35 years of age. He had a traumatic brain injury. Yep, he needs a low plus prescription with a little bit of a bifocal. But once we institute that, then you'll be able to do some of your vision processing and your oculomotor skills. And then I'd like to see him back in 6 weeks to see how he's getting along and see if I need to change that. That's how that needs to go. We need to have that dialogue. And I work a lot with OTs, PTs, and athletic trainers with that dialogue because once again, I want their expertise and I want them referring them back for my expertise, but maybe I can't see them all from that same perspective. And so this just helps get so many people better.
Oh, that's great. I really appreciate, that's definitely going to be a takeaway for me today. Okay, on to a couple of more questions about oculomotor testing. Do you test in fixed and random saccades or saccades? And if so, how many reps, seconds do you perform the test?
So once again, if that patient's breaking down pretty quickly, I mean, you go to where they're going to break down some point in time. So when you look at the literature, I think the standard is usually 10 times, right? Right to the left, to the right. But if that patient's breaking down, you can end that. What you're wanting to find out is, where is the breakdown for that patient? Is that patient able to succeed with saccades, but not with pursuits? And we got to really take a look at that. And are they symptomatic? It really comes out, if they're blinking a lot, they push your pen away. That's all indicating to you that they have a problem. So we might be looking, and this is where I don't have a financial commitment to right eye, but right eye can really find that in space and really determine that. There's been times where I've looked at a student athlete, and honestly, on my oculomotor therapy testing, I couldn't see the saccadic intrusion be that subtle. And so there are some high-tech things that we can utilize. One thing might be even using your cell phone and using the camera with the video and having the corneal reflex come off of that. You have actually built in your own little eye tracking piece that you can see how that person is doing with the movements that you give, and you can see those saccadic intrusions a little bit more easily.
And so did you use the term, did you say breakdown? Is that what you used?
Yeah, when the system breaks down, if they start to blink a lot, their posture changes, they move.
Okay.
I mean, those are all indications that that individual is breaking down, and you've met that point. So now they're compensating, or they're doing something in order to be able to get through that particular test. To me, that's just indicative that I need to be doing something that's a failure of that system.
So it would be looking at symptom provocation, a change in posture or an aversion, and then of course quality, like
Absolutely.
They're starting to undershoot or overshoot. Okay, oh, fantastic. Another oculomotor question: do you test smooth pursuits in the H pattern, in circles, and/or at various speeds?
All of it. Because once again, it depends on that patient, right? I've got to find out where that patient is not doing well. Because if they're coming to see me, then they're having headaches, they have light sensitivity, sound sensitivity. They've got something going on that is not allowing them to get through their day. So I'll start out with a pursuit slow just to see how those eyes move, and then I'm going to speed it up. I would take it 10 inches closer to them. I might take it 18 inches back. I want to see how those eyes move in that plane to see where that failure may be happening.
And one of the interesting things we've seen in the clinic, you talked about right eye, we utilize like a V&G because we're, Dizziness and Balance Center. And you do see differences in a controlled environment. So they have the video goggles on and they're tracking at different speeds. And then when they get in a room and there's a busy background, you can see a change in that. So I think even testing in different background environments is probably going to affect.
Absolutely. Whether you have a plain background or you put a busy background.
Mm-hmm.
Sometimes if I have an athlete who is somehow playing the system and I know they're worse than what they're telling me, I'll do the eye movements in front of an OKM situation and they'll break down instantaneously.
Sure.
Right? That's horrid.
Yeah.
Or I might do something like a Dynavision eye-hand coordination, 10 push-ups, have them jump up, eye-hand coordination, 10 squats, and then an eye-hand coordination for a minute, 10 burpees. They're throwing up in the waste paper basket. Guess what? That person's not going back to play football.
Right. All right. Is there a standardized tool to measure and record abnormal ocular motor findings that's non-computerized?
Or you could do the corneal reflex with video.
Okay.
Yeah, that would be one way to do that. Otherwise, they've always been really the view of the practitioner looking at that. And so that's why, once again, when someone has a really big problem, we can all see that. When they have a subtle problem, that's what's more difficult to break down. And so the higher tech becomes important. That all I can tell you is I did 249 concussions on right eye, and they were 10 to 1 to 1. Why 249? I don't know, but 10 to 1 to 1. So 10 times more of those individuals had a parietal cerebellum problem to one frontal lobe cerebellum problem to one brainstem. So even if I didn't have a right eye, I would be assessing fixations, pursuits, saccades in my best of ability, looking at symptom and symptom provocation. And then I would make a pretty big assumption that when that person got a concussion, they're going to have an ocular problem. And so I'm going to automatically do something to do ocular motor training, and I'm going to be doing something with vestibular, and I'm going to see what's going on with that neck. So the triad there is very common.
Absolutely, and particularly with whiplash injuries, and I think just the forces on the cerebellum and brainstem are really affecting the ocular motor and the cervical spine. Okay, I hear two different philosophies about the use of Brock string. It seems some clinicians use it in the early phases of rehab, while others say it should be done later. What's your opinion?
You bet. So the typical kind of thing here is that we do not want to put central visual tasks on an already disturbed vestibular peripheral problem. So if we look at the fact that it's a mismatch between the peripheral system and the central system, we need to be doing Brock string by keeping their periphery open and going beyond 18 inches. We do not want to stimulate convergence. And so convergence is not stimulated 18 inches and beyond, but we want to be able to have them keep their periphery open. And that's how we're able to train the ambient system, the peripheral system, without putting them into what's called focal binding. So oftentimes I see that people will do pencil push-ups. I would never do pencil push-ups in this particular regard because that's a central visual task. You're going to collapse that peripheral vision. You're going to focally bind them. And that's why sometimes when you're doing some of these exercises, you're finding that your patients are getting worse. That's because we've got to open up that peripheral system. We've got to get that vestibular system involved. And then we slowly but surely get into an 18-inch or closer type of training.
Okay, so on expansion of that, so beyond 18 centimeters, which is a common distance that we would do VOR, which is central, but are you not overly concerned about focusing on something central during a VOR exercise because it's beyond that 18 centimeters?
Part of that, but probably I've already given them a proprioceptive anchor. I use a lot of compression. I use a weighted leg, compressed vest, a TheraBand in order to give some sort of proprioceptive anchor. So I'm using as an initial type of therapy, if I'm going to use Brock Spring, personally I don't, but if I'm going to use that because that's what's available, we have to center up that proprioceptive. We have to provide that anchor. And so as a result, when we provide that anchor, move that out beyond the 18 and get that periphery to open up, you're going to have a much more successful Brock String event.
Okay, great. And also a little extension onto something you mentioned is peripheral central integration. Do you do a specific test for that?
So a lot of times you can do, there's something through Bernal, you could probably get, it's a colored visual fields. And there's a lot of information written on the collapse of the colored fields to indicate that we've got a peripheral collapse. So when someone has an injury, they don't necessarily have a scotoma or a visual field loss, but rather that peripheral system has collapsed. That's one way to have a technical training with it. Once again, you can test that by just how their symptoms are. If you put on a binasal occlusion and you find that with a small binasal occlusion that they feel that they're a little bit more centered, automatically you have a collapsed peripheral field. And so as a result, but you can also kind of like take it to the bank. Once again, these folks that have whiplash, concussion, and they're not walking well, they're not balanced well, we know it's going to be VOR, we know it's going to be inner ear, but we also know that that peripheral system is collapsing. And one of the ways that we can open that back up is just to get that awareness, but you can add tactile, you can add vibration, you could add that compression.
And could you go by symptoms alone? If I don't like busy places, busy patterns, kind of that visually induced dizziness, are you kind of assuming there's an issue?
I am. It's kind of like the Walmart symptom. It can be vestibular, but that vestibular is tagged into that ambient system. So they've got that system. Yeah.
And it's just so interesting to, I just can never learn enough about how much the optokinetic system drives the VOR. So yeah, a lot of interesting anatomy and physiologies, especially with the cerebellum. Okay, in your opinion, we actually sort of answered this. In your opinion, what's the scope of practice of non-optometry clinicians? We've already said prisms, and then I think you alluded to the use of tinted glasses is questionable. Is that correct?
Well, the only thing I'd recommend really on that, those can be very powerful, and you really do need to take a class or get some experience with them. I don't think you can just read the Erlin book and be comfortable with that. I think you have to experiment. There's a lot of times where we get anecdotal results from this, where a patient reacts to something that we wouldn't ordinarily notice that. But I think light and tint is extremely powerful. I use it a lot. I never send it home with my patient initially because it's that powerful. It can make them not sleep. It can disrupt their system to the point to where that balance and that integration really gets disrupted. So I just think that once again, it can't be just, oh, blue works for this and gray works for that. You have to test that patient, whether you guys in PT and OT subscribe to muscle testing for that. We look at balance and how their symptomology may be, how they might be able to react in a ocular motor setting with that tint. But once again, I think that it just can't be use this for that and that for this. I think we have to be a little bit more knowledgeable and know that we can change that patient pretty radically with that.
Yeah, it's interesting. I saw a patient a few weeks ago who was worse after someone, it was their just general optometrist had given them yellow tinted glasses post concussion, and they were worse. And it was but the reason they were given was because they felt like things weren't as clear. Their contrast was affected, but it was actually making things too much contrast for them, and
too much movement. So what ends up happening is that's the problem when you do an exam in a chair, and then you don't take your item and put it in movement and put it in a distracting element and figure out how they cope with that. Very rarely, as you would know, would a yellow tint would ever work with that. I can totally understand that in the chair, they put yellow tint on there and the patient goes, oh yeah, that's so much clearer. What did we just do? We focally bound them because they were drifting in between that peripheral and that central vision. So we locked it down in that. And then once we locked it down, now we've collapsed that peripheral system, made things too bright. We've made the brainstem react differently. We've had the superior colliculus reacting differently. They can't walk through their space. They can't map it out. So yellow tint would collapse that system in 2 seconds.
And just, I love how often you come back to anatomy and physiology, because unless we have a pretty good understanding of A&P and how all of this works, or at least continue to try to understand it the best we can, our tools are limited. Our tools are often limited in a test finding something. And so just always thinking about what we're doing in A&P is I always have so much fun listening to you talk. Okay, do you train central first, then peripheral vision? You already kind of answered. I mean,
never. I'm always in peripheral.
Okay, you
everything that does peripheral. Yep. So, if I wanted to do a catch-all, and I'd be careful of that, blue is better for our peripheral. Opening up that system is better for peripheral. Compression, giving a proprioceptive anchor is better for that peripheral. Laying them down on the floor and letting them have that gravitational spot on their body for anchoring is better than anything else. So I start absolutely in periphery, and then I'm always checking to see where that vestibular's at. And then I use the eyes where I can in order to do that oculomotor. Saccadic training absolutely influences posterior stability, but we can't always do that. But if we do it from a lying down position where they're safe, because that's what they want to be, we know that when we sit them up, their vestibular system is going to respond differently, but at least we've given them an anchor in the supine, and then we start in the seated position, and then we get them standing. But the biggest thing is that ocular motor system really plays well to the rest of the posterolateral and the extensor and flexor system.
Yeah, and I think in so many of our patients, the cerebellum, there is affected in how it inhibits. And so when we get in that supported position, I think it allows the cerebellum to work a little bit better.
Absolutely.
What are your top 3 exercises for convergence insufficiency? And then it says, and what about divergence?
Okay, so, and sometimes that can be very difficult, correct? But at the same point in time, I'm going to try and use some proprioceptive anchor. I'm going to also take a look on where they're at with that. So if I have to do it seated and I give a proprioceptive anchor, then I'm going to do something out in the periphery. Once again, we do a lot of Stroop further out. I'm going to add a cognitive load symptom limiting to that, and that seems to help shore that up as well. So I'm going to start with that proprioceptive anchor. If the proprioceptive anchor does not work to help that patient do better, then I'm going to start looking at maybe a tint. I'm going to be looking at something different like that. But usually the proprioceptive anchor works very well to settle that system down. And then I'm going to use a vestibular activity, perhaps with a cognitive load, if they can tolerate that, further out than 18 inches. I use vibration a lot. And so a lot of times, very subtle type of vibration along with a Stroop test, if they can tolerate that. So I'm doing lots of symptom limiting cognition types of things along with that subtle vestibular, but shoring up that proprioceptive anchor.
And I just, for our listeners, when you say proprioceptive anchor, it could be a weighted vest, it could be manual, it could be TheraBand, it could be the support service. Is there anything else that you're thinking about?
A t-shirt one size too small works absolutely brilliantly, because then people don't feel as conscious about it. I had a lady that actually had a stroke at 42, and she had a struggle with where she was in space. I just asked her to come to therapy with one size t-shirt too small. She stopped using her cane within 2 weeks, and it was really able to give her that ding back of where she was at. And then we were able to move faster for her, because then she didn't have to worry about falling as much. So it really helps with securing that anchor.
And then just again, for clarity for our listeners, when you say the Stroop test, are you using the Stroop test specifically or just a general cognitive test?
So you can use a general, but I blew up a Stroop poster. So it's much bigger than the small ones you see on the internet. I blew it up to be bigger. Why? Because we're not wanting to do that focal acuity type of thing. It's not about that. It's about doing some very subtle types of things. So we might start out with the color and the word being the same. And then the next step might be obviously the word and the color being different. But like I said, I have them blowing up 2 or 3 times. So we're not worried about acuity in that point in time. We're just wanting them to get the general large area.
And do you monitor that, like record it to see if they improve from treatment to treatment, or is it just, I mean, sometimes it's hard to monitor that and keep a recording, but do you try to track the success of the Stroop test while you're doing a sensory reweighting?
Absolutely, because, you know, once again, they're computers, right? They want to know how much better they're doing. What's nice about using something like that, because you can say, gosh, you got 6 today, and you know, last week you only got 4, or maybe you got 1. And so as a result, that computer in them, that desire to do better, that helps facilitate that as well. That's what's making flipper training and eye training, although we do a lot of that. I don't have any way to tell them, oh my goodness, you're so much better, because, you know, we don't have any way to objectively look at that. But we might objectively look at it from balance, from gait, and then also looking at that cognition.
And can you just explain quickly flipper training?
I'm sorry. So what happens is that Dr. Barry Tannen came out with an idea that a +2, -2 flipper done in a rhythmic fashion. So they have to clear it at 16 inches, clear it, clear it, clear it. So when the vision gets cleared with a -2, we're using accommodation. When the vision is cleared with a +2, we're calming that accommodation. And if someone has a concussion, traumatic brain injury, they will not successfully be able to do 16 cycles in a minute. And that helps decide whether or not we need to do something with their vision. So that would be one way to determine whether or not we need to be doing something else in a testing situation. And also came up with base in and base out prism in that same, is if you can't do 16 cycles in a minute, then we need to be doing something with that visual system.
And because the flippers have a power in them, again, that would have to be directed under an optometrist, neuro-optometrist, just for clarity, correct?
Yeah, that is correct.
Okay. And okay, do you train one eye at a time, then progress to binocular vision? When do you know how to perform monocular over binocular?
Well, I start out with testing. So I'll test them monocularly first, especially if I've got a stroke. So different types of things. If I have a stroke patient or I have a traumatic brain injury patient, I am going to do monocular first. I want to see what that's doing. And then I'll look at binocular. Do they have a 3rd nerve palsy? Do they have a 6th nerve palsy? What do they have going on? And so once I determine monocular, then I'll do biocular, where you can have a setting where both eyes are open. They're looking at, but you may have a septum in between, so they're getting different information. And then you can put them together as binocular. Binocular is going to be the most confusing because you're trying to get the most amount of information. So when you're doing binocular, sometimes doing a binasal occlusion very gently on the glasses for that patient will take away some of that distracting information.
And when you talk about the biocular, I have never done that. Is that something you just made in the clinic, or is that a kit that can be ordered through Vernell where you can set them down, and how do you do that?
Yeah, so actually sometimes I just use a piece of paper just to give them a septum, and then we determine what they're seeing. And we might have, the other way to do that would be red-green glasses, where you're looking at different information. So the green's on the left eye and the red is on the right eye. And so we're able to have them turn on and off information from that biocular system, and then we put them together.
Okay, great. And someone has asked a question about your book. Is it available in paperback or in Kindle? And I believe it's both, correct?
It's on Kindle. I believe it's in both, that you can get a paperback or Kindle. Yep.
And we will be providing you the link on Amazon of that. Actually, I believe all your books are on Amazon. Is that correct? Okay.
That's
yes,
correct.
We'll provide our listeners a link to that for sure. Okay. I guess I want to have one signed. You know, like,
I'd be happy to do that.
I hear about nasal occlusion frequently, but I don't fully understand how it works. Can you explain the rationale And how much do you occlude the lenses?
So if someone who has had an injury has a visual mismatch, sometimes getting rid of some of the visual information in that field can allow the brain and the eye to operate a little bit better. So you can use peripheral occlusion or sector patches and achieve some of the same thing, but the most common one used would be a binasal. And you don't use a lot, it doesn't require a lot. You could put on probably only about 3 millimeters of tape on each side, and that person will begin to notice that the vision out in the periphery is not as confusing. And that's because the tape obviously is blocking some of the information that overlaps. And so now the brain doesn't have to take and discern what it needs to pay attention to. So in our visual fields, our two eyes overlap in that visual fields. And by using that binasal occlusion, we are reducing the amount of overlap information coming in. So now the brain can process this is coming from the right, this is coming from the left, and this is what's crossing over. And what we're trying to do is get the crossover to be a little bit less.
And how long do you have patients wear the nasal occlusion glasses?
I absolutely will use them in therapy. And if they are doing well with them, I will send them home with it, but I never leave anyone in a binasal occlusion longer than probably a few days to a week.
But will they wear it constant for those few days, or do they just 5 minutes, 10 minutes?
Oh, some do. I have some that wear it constantly, maybe for a few days, but I'm constantly then making it smaller and introducing more information to them so we can reduce that. I only have one patient that had a traumatic brain injury. It was an assault that's in a little bit of binasal occlusion probably now for a year. I ordinarily wouldn't do that, but that's just how he's able to perform. I don't have a single other patient that needs to have it for very long.
Okay, and do you use a specific tape, or is it just any tape, Scotch tape?
Scotch tape will work. What you want to do is just make sure, I think Scotch tape would be a good thing to use because you want to be careful with certain kinds of adhesive on glasses to make sure it comes off. So Scotch tape works very well.
Okay, great. And could you please explain or review tropias and phorias and when physical therapists should refer out?
So cover test will help distinguish between that phoria and that tropia. A tropia is probably best described as an eye that it's constantly misaligned. And that misalignment may be the right eye is turned in all the time, or the eye is turned out all the time. That would be a tropia. They never have any stereopsis. On cover test, you'll find that some patients can be alternating esotropes or exotropes, and that makes that a little more interesting. On a phoria, what you're trying to determine, obviously on cover test and alternate cover test, is behind the cover, the eye will go in either an out movement. That would be an exophoria, because when you uncover that, the eye comes back into binocularity. If you have an esophoria, you'll cover up that eye and that eye moves in. And the moment you pull that cover off, that eye goes back to the appropriate position. It's when you cover the good eye, let's say the right eye is the good eye, and this eye is turned in, you cover the good eye, and finally, slowly this eye moves out. And then you cover the left eye, the bad eye, it moves back into this position. Remove that cover, and now that eye doesn't move because that right eye is the eye that that patient uses. What can be confusing is you can have an alternating esotrope or exotrope. That means they might use either eye, but they're never getting stereopsis. They never see depth.
Interesting. And do you see phorias develop into tropias?
So you can possibly have that if you have a situation where it might be neglect, meaning that we're not doing something to cultivate that individual's eye care, and sometimes nutrition. So if we see patients that have been neglected in many fashions, you can certainly have somebody who could have had a high phoria now goes into atropia. Sure, they suppress that.
And do you have any recommendations, kind of same to this question, for non-optometrists if they're performing the cover, the alternating cover, any red flags? I mean, we typically look at double vision as a red flag or a skew deviation, but do you have any recommendations of red flags like don't do, intervention, refer?
Yeah, sometimes I hear, because I try to listen to a lot of classes too to see what's out there. If you have a patient that's presenting with an esotropia, but they may have a late onset with that, or they've not been officially diagnosed, I wouldn't touch that person with a 10-foot pole until they get tested. I had a patient come in, she's 22 years of age, I never saw her before, but she never had any complaint of any tropia. She presented with an esotropia. And my immediate response is I did my exam for structure. I did a visual fields. I found out that she had a visual field defect, and I referred her out for the potential blood workup and for an MRI. And what happened is she has a thyroid difficulty, and they found a pituitary tumor. So that's why you got to have a diagnosis, and you got to know what you're throwing your dart at in order to determine that. So even for me, when someone calls me up and says, oh, I've never been in esotropia, or this just started to present itself, we have to determine why it presented itself. And then we have to rule out any type of structural problem.
And I had attended a course one time with a neuro-optometrist who talked about assessing for normal physiological diplopia and had recommended to non-optometrists, obviously, if the patient does not have normal physiological diplopia, to be cautious about exercises. What's your opinion on that?
Well, if you have a patient that presents and you do a baseline acuity and you find that one eye is 20/20 and the other eye is at least 20/30 or worse, I think that needs to be referred. If you have a patient that's presenting with double vision, and if they still present with double vision with one eye, that indicates a potential of refractive error. If they present obviously with double vision of a recent onset, we have to rule out hypertension, we have to rule out a brain tumor, we have to rule out a brain bleed. So once again, I think anything that's sudden or acute, we need to get a better handle on that before we can do anything with it. And then people who are tropias or strabismus or amblyopia, we have to be very careful about stimulating that. They've already learned how to compensate, and we want to make sure we're not patching and turning an eye on when we shouldn't. So that's where those things that even some of my optometry friends will need some assistance on, because maybe they don't see it all the time. And so that's why we want to be working together.
And when you patch, are you a believer of clear patch and as little patch as possible, as well as alternating eyes? What's your opinion on patching?
Well, once again, I don't believe in full patching. I believe in spot patching. I do have a gentleman that had, he was taken up 25 feet and dropped on his head, so he got a compression injury. And so he has a lot of vestibular and a lot of ocular motor difficulty brainstem. So the only way I can get any therapy to work with him is I take a foil and I've blacked it out a little bit. And then I gave him a pinhole that actually is in a U shape, because that's how he functions the best. But by taking away the peripheral vision in his left eye, giving him full peripheral vision in his right eye, he can actually function and drive and walk. So that was the first time I ever prescribed a U-shaped pinhole and blocked out the periphery. So everyone is so unique, but spot patching I think is great, because you're still getting the periphery in. With a third nerve palsy, spot patching is great because they can still use that eye in the periphery, but they don't get the double vision. And so spot patching to me is best. I would not use a full patch for anyone. Okay,
thanks for that. And there was another question, late question. Actually, you've already answered this one. Are Prism lenses worn 100% of the time? You have answered that, but what I do think is interesting about what this person wrote in is they saw the Prisms work fabulous, but then the patient went backwards. And do you see that happen? Do you see where it works and then suddenly it doesn't work? What's your experience with that?
Everything. You try something and something doesn't work. But the key thing with that is that once you put a prism on them, once you've done that, you've changed that system. So we have to do other things in order to help that system. So either they grew out of the need for that particular prism, or some of the therapies that we did in adjunct to that prism is not working. So if we can think about the prism affecting that cerebellum and affecting that vestibular system, then once again, that may help the OTPT athletic trainer to determine what kind of exercises they should be using. But once again, I still got to see that patient reasonably frequent in order to make those changes in that prescription, because once they adjust to it, it's no longer going to work the way I want it to work. I want to change their space and their perception of that space. I might need to take them now out of that prism.
And it says that patient added all her previous activities, returned to running 20 miles per week. You know, what I'd like to, a question I have is, I've heard you say the word injury quite a bit, and is that related to how many patients you see post-concussion? Because I also could think of injury as basically any disruption, stress, mental stress, physical stress, having the onset of vertigo. You know, I think what happens with our patients is they've maybe compensated for phorias or for something with their visual system, but then they get the onset of vertigo and now they can't compensate for that. And those things that maybe they subconsciously compensated for, their now it's an issue as an adult. What's your experience with that?
Yeah, you're absolutely correct. So number one thing that I do in the history is to find out, was there some sort of a physical thing that caused them to change, or could it be emotional? Could it be stress? I had a patient come in who got vertigo, and she ended up having a tooth done. They did a root canal, and being in the chair and how they administered the anesthetic, she ended up with a problem, and normally she can compensate for it. So I try to find out what it is that stimulated what's going on. You know, is there a lot of stress? Was there a head injury? Do they have a stroke? Did they take a medication that perhaps is a high blood pressure medication, or a thyroid medication, or a diabetic medication? Those all will disrupt what we're doing. And so we can't take them off that medication, but we have to determine, is that where it started? And if that's where it started, then how can I help them get better? And that's where I still go back to that brain anatomy. What things are indicating to me that they have a frontal lobe problem? What's indicating to me that the parietal lobe is more affected, or their cerebellum, or their brainstem? And then once I can determine where the symptoms might be coming from that, then I can better treat them and get them sleeping, get them eating appropriately. How many kids do I have come in that had strep throat, and now they have something called pandas? They have a tick, that sort of thing. And that's really related to changing their diet and getting their vestibular and their proprioceptive system moving, so we can get rid of the trash that's in their system and get them back to who they are.
And over the last, you know, year and a half with COVID, I do think in our practice, we have seen a pretty significant increase in visually induced dizziness, where yes, there's a vestibular component, but an even greater visual component. And so when, you know, we think about the cerebellum and the brainstem and processing all that motor part, don't you think that could also be downstream from the elevated sympathetic nervous system and affecting the way that inhibitory process? Have you seen that change or be different since COVID with your patient population?
Absolutely. So that's the other thing I look for, is that autonomic nervous system connection. So we look at that parasympathetic sympathetic system, and I use a product, just a snapshot in time, to look at heart rate variability. Then I'll compare that to my right eye, and then I'll compare that to my neuro exam. And so in my patients that are either long hauler COVID patients, or patients who don't believe they've contracted it, but now they're not thinking correctly, they got foggy brain, their eyes don't work, we treat them as a concussion, and we had great success with getting them better. But these COVID patients are presenting foggy brain. They're presenting just like a concussion patient, and not unlikely. Why? Nasal, that's the thing that's exposed the most here. Olfactory is your frontal lobe. And so as a result, their frontal lobe goes offline. And so we got to try and bring that executive function, that cognitive back.
And for anybody who tuned in the latter part of this, when Dr. Fitzgerald says right eye, she is talking about a machine, not just the right eye. but actually right eye is a machine that assesses ocular motor movement. So we are, up on the hour. If anyone else would like to spend a minute or so here asking any questions, certainly take advantage. We appreciate you sending in so many great questions. And I don't see anything coming across here. We'll provide you the link to the various books that Dr. Fitzgerald has written. And as always, it's such an honor. I appreciate your time. I appreciate the time of our listeners and joining us today. And for those of you that could not make it, this is recorded and will be on our 360 Neuro Health YouTube channel. So big thanks to all of you.
Thank you so much. Yep.
Okay, we do have a question here. Is there any specific continuing education or courses that you recommend to non-ODs?
So Neuro-Optometric Rehab this year will be online. And one of the classes that we're doing is a non-OD primer class taught by Dr. Melissa Zarn and her staff of OT and PT. I think that's a great class to take. Melissa Zarn does a great job with it. Any other classes that you wanted to take online with NORA, you can certainly do that. But I would certainly look to NORA. I think they do a great job.
They do a fantastic job. And Jackie, thanks for your question. And I know that you had emailed me a longer case study question that I will take a look at and break down, and probably end up running by Dr. Fitzgerald, because it does definitely seem like a visual component to that. So thank you all, and we'll see you next time.
Thank you. I appreciate it. Thank you, Bridgett.
All right. Thank you so much.